Morning. My name is Ann Brazo. I am the founder and CEO of MPN Advocacy and Education International. Many of you know who I am. I've been around for a long time, 17 years in the MPN space. I was with the MPN Research Foundation first for almost 9 years. And in 2013 started this organization so we could solely focus on education and advocacy for the MPN community. Today we're talking about transplants, and I have fabulous guests with us whereby you will learn quite a bit, not only from a physician and researcher who has been dedicated to MPNs and transplants at the Mayo Clinic in Arizona, Dr. Jeanne Palmer, who will speak first to you. And then you will hear from Dr. Michele Couri, who has actually spoken at a couple of our women's events. She is a gynecologist and a patient who has just undergone a transplant. And then you will hear from a caregiver and another patient who has gone through a transplant. I thought it was necessary for all of us to hear the caregiver side of the story as well, and that will be very useful for you. Your questions can be posted at any time. The sole reason for doing this is so you have an opportunity to ask as many questions as possible, and we will try to get to all of them in this 2-hour span. So first, please welcome Dr. Jeanne Palmer, and she will give her update on what's happening at the Mayo Clinic and transplants.
All right, thank you so much, Ann. It's always a pleasure to be at these events and be able to talk about transplant and how it fits into the treatment of MPNs. So as many people out there probably know, transplant is one of the, and the only at this point, curative option for myelofibrosis. It's a treatment, however, that scares the bejesus out of a good number of patients, and for very good reason. As we all know, transplant is a fairly intensive procedure. It requires a lot of patience, and sometimes people are pretty terrified to go. I think one of the key messages that I do want people to remember, other than that being terrified is normal, is that it also is a procedure that has a great deal of hope. I wouldn't be able to keep doing what I do every day if I didn't have people succeeding and going on for years with very successful outcomes after this. So even though it is scary and there's a lot of data out there that can be very scary, it also is important to realize that it is something that is a curative option and can be actually extremely helpful in terms of treating this disease. The other thing that you need to remember is that you always want to do the transplant before you think you need it. Because I think one of the hardest parts about transplant is everyone says, well, this is my last, I'm reserving this for the last thing. This is what I'll do if nothing else is working. And if you take that approach, it's actually not the best approach to take, because you'll probably be so sick at that point that the outcomes won't be as good. And I think historically, when we look at some of the data that did show outcomes that weren't as good, it was because we did wait till the end. We waited till people were very, very sick and didn't have any other options. So I think the key here is sort of like, you know, if you're doing a long distance exercise, they always say eat before you're hungry and drink before you're thirsty. And so it's really important to get a transplant before you feel you need one. The key to deciding the timing of transplant is elusive still. We don't really know what the best time frame is when exactly a person should go to transplant, because that's the other big question that comes up, like, when should I do this then? If you're telling me that I should do it before I think I need it, well, when should I? And that's a very personalized decision. I think that there is a window in which we want to do the transplant, and that window varies from person to person, and sometimes we have, I think, more time than others. But there's a starting point of that window and an ending point of that window. Now, excuse that, they're doing a lot of construction outside, so if you hear a lot of noise, that's what it is. But when we think about the timing of transplant and how we assess that, that's where some of these risk stratification tools we have. Everyone's heard of the DIPS plus, and then there's MIPS and GIPS and every other IPS you can possibly imagine. At the end of the day, these are all guardrails. They are not set in stone, like this is absolutely what you need to do. So one of the keys to figuring out timing of transplant is understanding your risk and making sure that you speak to somebody who really understands MPNs rather than just transplant. And that's one of the hardest things, because I have wonderful transplant colleagues who still don't quite get the intricacies, and they'll say, okay, well, this data says you can do it this time, and this data says this time. But putting it all in perspective to understand the risk of it, when the appropriate timing is, it's very important that you make sure you speak to somebody who really understands MPNs and the nuances of how these different risk assessments were generated, and how they can apply to a patient to you. And that's something that we're still learning how to do. And it does become a very shared decision-making process. So once we get in this window, then it becomes a conversation that I have with patients of, okay, what does your timing look like? What is this? What's going on in your life? What are important things? But understanding that these are the factors that are very important, and we don't want to let too much time go by or too many things change in your disease, that then it would make the transplant outcome not as good. And so that really is an important discussion to have. It's important that as a patient, you understand that there is some flexibility in this, but that there is, that needs to be an ongoing discussion. And you also have to really trust that you're getting the information that you need to say, okay, these are the different risks. This is how I apply them. And so you're educated when you do have this discussion in terms of the timing of it. And that's something that's not easy to do. So I think that I won't talk any longer because I'm sure there's a lot of questions. But I guess the take homes of what I always want to say is, number one, there's hope. So people do have good outcomes. We're getting better at this, especially when we time it appropriately. And number two, know your risk and realize this is a shared decision-making process. It's not one of those things that you can come in and the doctor should say, okay, this is when you need a transplant. It is very much an ongoing discussion about where you're at with your disease. And so it is a very much a shared decision-making.
So two questions. One is, what if the physician is saying, maybe not because of your status, so much, but because they're reluctant to say, go ahead and have yes, you're a candidate for a transplant, even though they meet all the criteria. But it's, sometimes the physician will put up the roadblock because in their minds, they're worried about what happens afterwards. And can that person sustain, go through the recovery process? So it probably depends a lot on who you're talking to in terms of the provider. So, I know that there's a number of even physicians out there, even some of the people who treat MPNs who maybe aren't as pro-transplant and sort of have different viewpoints on transplant. And a lot of our viewpoints are based on experiences. I mean, we're humans. So as much as we try to rely on data and rely on that, the data for transplants, are very flawed. You can poke a lot of holes in them. But more importantly, if somebody trained 20 years ago or trained, I finished my training almost 15 years ago, you remember a lot of stuff from your training, and usually it's the more traumatic things you remember. So if you remember a bad outcome with transplant, you're going to have an inherent bias against it, even though there's lots of data and stuff that may indicate that it is and lots of even physicians who do the transplants who say this can be a really very, give you back life. So I think it depends on the provider. Now, if it's a transplant physician who's saying that, transplant physicians also vary from more conservative to more aggressive. And so there's been times where I've actually said, I'm not sure that now's the time to go forward with transplant. It doesn't happen that often. Usually, we can kind of come up with where our guardrails are and figure out a time to go based on deciding together. A lot of times patients come to me because they're like, well, do I really have to do my transplant? Because they'll say, oh, well, somebody told me I have to go now because of this one mutation. And I'll say, well, let's talk about this and figure it out. So I think it really depends on who's telling you, who's conveying this, because there's going to be a lot of inherent biases. And then there's also going to be inherent differences between even transplant physicians and their degree of aggressiveness or not. And that's where it becomes very confusing to patients, because I tell people that this is the hardest transplant to do. So there's easier transplants where consultations where I'll be like, you have this disease, you need a transplant, period. Whereas other times it'll be like, well, there's a timing thing here. There's so many factors that we have to take into account that it becomes a little bit
harder to have that conversation. So I hope that answers the question.
It does to some degree. And, you know, we have a couple women here that can also speak to that. Michele, when who determined, when you decided to have the transplant, I'm assuming it was a long discussion with your physician, but was there pushback or, how did that process go for you?
Anne, can you still see me okay?
Yes, I sure.
Okay, because I've lost you, but I'll find you. So the process for me, my polycythemia vera progressed to myelofibrosis in 2020. And I also was diagnosed with 2 somewhat aggressive mutations in addition to JAK2. I found that out in 2020 as well. So the combination of the progression of my disease and those 2 mutations made it pretty evident that I was headed towards transplant. So it wasn't necessarily ultra urgent, but I did do my due diligence and I took my time in finding the right transplant team. And I think that's critical, is to feel very confident in who's going to do your transplant. You have to feel so comfortable in basically putting your life in their hands, because they're navigating the ship for quite a while. And I think that's really important. But and I agree with everything Dr. Palmer said. It has to be, the shared discussion of between your transplant team and yourself about the goals and when it's the right time.
Denise and Andrea, you two are a team, and, and Michele has a family. So, I know that not only discussions with the physicians and the medical team, but discussions among yourselves and, who's doing what, and is this, how is this going to work for the family? Denise, do you want to share a little bit about how you decided to have the transplant? And I mean, you mentioned Dr. Palmer, but.
Excuse me. You mean me, Anne? Okay.
Oh, okay, I'm sorry.
That's okay.
Did I switch you around?
Yeah, it's all right.
Patient.
Patient, yes. I'm almost 3 years out. 1 month I'll be 3 years out. And the decision process was probably the most difficult decision I've ever made in my life. I had 3 months. Once I made the decision, I had 3 months to prepare. And you really do need preparation time, because I was away out of the house. We were away for over 3.5 months. Pardon me. And so you have to handle any pets, any bills, any mail. I put security cameras up so we could monitor. I mean, you're moving for 3.5 months and there's no way to get back to check on things. So that's really important. Denise can talk about something.
Yeah, and I can't reiterate, of course, what Dr. Palmer and Dr. Couri have said. The communication, the whole package is important. You can't just focus in on one particular scenario. I took I had the luxury, if you will, of a more observant type of participation in with Andrea's transplant, while she was involved in, and I was involved in some of those calls, but she called lots of different people. What's it like? Give me the day-to-day spiel on what is a transplant like. I also then looked at her overall health and said, okay, here's where you are. And being part of her journey for the last, from when she essentially had ET and then changed into myelofibrosis, really gave me a picture to see her progression of her health. And I took that into account to see as she declined, in the sense that the clinical trial wasn't working, she was maturing in her years. The things that she wanted to do in life were we were modifying, and which is great. And we modified all the way, but there were more and more modifications, and she was still in good health. And so that was kind of the time to say, do it now while you can, because down the road, as we all know, we're not 20 anymore. and it's going to be harder to recover, and it's going to take longer to recover. So do it while you feel good. As crazy as it sounds, you're better off. From our experience, it was the best decision to make.
Right. And Dr. Palmer, you know, we were talking about statistics. Is Mayo keeping track? I'm assuming you are. You know, how many patients have had a stem cell transplant with MF? How many achieve a cure? And is it sustainable? I mean, you know, are people tracking this? And what is the mortality within 3 years? There's a list of questions here from one person, but, and can you talk about GVHD, graft versus host? I mean, there's a lot of questions there, but.
Right. So, you know, when it comes to, so in terms of specifically here, we probably do about 8 to 10 transplants a year for myelofibrosis. And I would say that the outcomes in general have been very good. When they have not been good, it's often been because somebody comes in with much more advanced disease, or having progressed to, you know, acute leukemia or blast phase or something where the outcomes do become a lot more challenging. Not impossible, but definitely increased in terms of how challenging. But when you look at transplant, people always say, well, did this work? Did this work? Am I cured? And I try to say there's several phases of it. The first phase is do you engraft? Because that means your cells come in, do your cell counts recover with the donor cells? And that we know pretty early on. Depending on the transplant center, we check, you know, how much is donor, how much is recipient pretty early on, and can sort of give a better sense of that. Now, and sometimes even we, you know, depending on how the donor recipient thing is assessed, even if you're not 100% donor, that doesn't mean you failed. So, because there's a lot of nuances to how we measure that. And then in terms of the next measure of success is, do you survive the first couple of years? If I think of when do the most complications happen after transplant, it's usually actually within the first year that we'll start to see a lot of the problems with graft versus host disease, mostly infection. Now, having graft versus host disease isn't entirely bad. When I give this talk with a crowd of in a room with people rather than on Zoom, I usually try to kind of give a pictorial thing by having half the patients stand up, because it really, when it comes down to it, you can sit there and go through crazy statistics. But I think graft versus host disease in my mind becomes very simplistic. Half the people will get it, half them won't. Getting graft versus host disease is not all bad, because it might mean that this new immune system is actually working against your disease, as well as, unfortunately, working against your healthy tissues and your skin and your gut and liver. The vast majority of people who have graft versus host disease will respond to treatment. We give you steroids, you might not sleep well for very long, you know, for a while, and you might, you know, get some weakness in your legs and have some of the other complications related to steroids, but a lot of people respond. Now, the nice part about graft versus host disease is we've actually gotten more approved treatments for it. So we've gotten better at treating it. So then when I say, you know, if you take that 100 people, 50 of them are going to get graft versus host disease, 10 to 15% get it very severely, where it does impact quality of life, where it really can be a prolonged process of it. Most of the time we know this in the first year. Sometimes people will develop graft versus host disease in the second year. But we usually kind of know where we're going, or sort of have an idea at that point. There are other transplant-related toxicities that are kind of a little bit beyond where I'd like to go with this discussion that can happen, but are still manageable. So this is certainly by no means the depth of what can happen, but that's what we look at up front. Now, in terms of the relapse risk is actually pretty low. So if you come into transplant without having a lot of progressive disease, in terms of the percentage of the blasts or baby cells, immature cells that we see, if you come in with sort of a chronic phase of myelofibrosis, the relapse risk is probably between 15 and 20%. So it's actually a lot better than some of the odds I give for other diseases that are transplanted. When the disease has progressed, sometimes those odds aren't as good. But the relapse can occur, unfortunately, it can occur later on, but the longer you go that you're in a remission and with the full donor, I think the more options we have after that. And a lot of times, even if the disease does come back, it's not like it comes back rip-roaring bad. Sometimes people come back with sort of that chronic phase, and we could treat them just as myelofibrosis. So depending on your age, your donor, we can be thinking about second transplants versus, continuing to treat it. Again, we're still not looking at a huge percentage of patients. We're still looking at a small percentage, probably 15 to 20% who will relapse at some point. So I think that the outcomes are actually not nearly as dire as sometimes they seem.
Well, you kind of touched on two things. One was the donor, and I'd like to ask both patients about their donors. Michele, I believe you mentioned your daughter. Could you explain that?
Yes. So there was no perfect match for me in the national, registry. So my transplant physician tested 3 of our children, and one of my daughters came back as the most ideal donor for me. So she was my haploid donor. She's a 16-year-old.
That's really wonderful. And Andrea?
Yeah, for me, actually, I have 2 sisters. One, we went to them right away. We did not go to the national bank. My older sister did not match. My younger sister, who's younger, but she's still was in her early 60s then, she was a 10-10 match. And she also was my co-caregiver. She helped Denise out and was with me for 3 months. So
that's great. That's great. Both stories great. Jeanne, we got a question about how young a person can be to be transplanted, and what do you look at them differently, and what is the age limit? Do you have to be 18 or older to have a transplant?
So I wouldn't say there's a younger age limit. I think the limit is mostly on disease, making sure that we think about it in the appropriate fashion. So for example, if somebody has really early disease, or sometimes, and isn't very advanced, then the life expectancy is long enough that we wouldn't do the transplant. But I wouldn't do that based on just age by itself. It's the decision to transplant is based on disease risk. Now, I'm sure a lot of people are wondering, well, what's the upper age limit for transplant? Now that is fairly center specific. We, like here at Mayo, our upper age limit is 75. I will say that even though we can certainly achieve good outcomes with people above 70, it's a harder road. But it is still something that we do. Now, other centers have higher age limits. Other centers may have lower age limits. So it really, I'm sorry, what?
I was just going to say, that there are many younger people now being diagnosed with an MPN, and I mean younger, below 20.
Yeah.
And so can someone below 20 have a transplant?
Oh, absolutely. Kids actually, people under 20 do better with transplant. It's sort of with each decade of life, unfortunately, people tend to do a little bit worse with transplant. We know that probably up till about 35, and it really depends on the study you're looking at and stuff, people are in a better age category to get a transplant. However, unfortunately, most people who need a transplant are above that age limit, but there's definitely no lower age limit. The one difference I would say with somebody who is younger is we might be a little bit more aggressive, just because in younger patients, I think we sometimes would be in that, especially if we see bad prognostic features. So that might be something that would impact how we would treat.
Okay. As I mentioned, we do have a lot of very young people. I mean, below 20 that have an MPN, and I'm sure they're looking to the future, thinking, what's next, and should I do it now, or and again, that's a conversation with physicians and family. And how old does someone have to be? I mean, Dr. Couri just said her daughter's 16 years old. So you kind of answered that question, to be a recipient or to be a donor.
So to be a donor, I mean, especially when it's a situation like Michele's, where there was not a good match, using a half match donor, that becomes a very personalized decision. I mean, we've used donors at 11 years old even. And so I think it really becomes, what the family dynamics are and everything else. So I don't, and if you look at for kids, you know, if kids get transplanted, often they use their siblings, even if they're really like 5 or 6 years old. Now, the limitation is, of course, body mass. So you can only take so many stem cells out of somebody. And if the donor, it weighs far less. So let's say the donor is a 10-year-old and weighs like 50 pounds and the recipient is a 200-pound parent, there may be some challenges in terms of figuring out how to get the appropriate number of stem cells. But depending on the method in which we use to collect them, that can vary.
Okay, so this is a question for all of you. And that is, how do stem cell transplant physicians handle fear and depression in the patient prior to the transplant? If you in fact experience that, Dr. Palmer, you can answer first, and then I'd like to hear from the 2 transplanted people here and their caregiver.
So I think
Jeanne?
that depression, you know, which is tied in a lot to fear, there's a lot of different areas. So I think that pre-transplant, especially when you're at the point where we're trying to say, look, let's not do a transplant, you know, we have time before we need to, that waiting period is tough. Like the idea that this transplant's hanging over your head, I think that's very challenging. And some people are like, well, just do it, just get me transplanted. And it's sort of trying to explain, you know, the risks and benefits and reassure people and help them sort of focus on living in the day. You know, the peri-transplant period is incredibly difficult because all the meds we give you, I mean, everything we're doing is messing up brain chemistry, which really makes it a lot harder to manage moods and everything else. Long term, I think the hardest depression that we handle is actually, you know, a year or 2 out, because then somebody's kind of getting back to normal. They don't have as much contact with the transplant center. They don't have the structure in their life that the immediate post-transplant has of you need to get labs this often, you know, and that's when people really struggle, because it's all of a sudden like, you're letting me go. And, you know, the reality actually has a chance to seep in because your life isn't so structured in what you're doing for transplant. It's almost like this adrenaline rush. And then all of a sudden trying to get back into life is incredibly stressful. So I think that's hard. Now, what I usually try to do is be very cognizant, you know, and try to, you know, open myself up so I can sense how they're feeling, and then have a discussion about it. Because there are a lot of very, very good treatments out there for depression. And I always tell people these aren't happy pills. They help you balance the waves. So the waves aren't like this of ups and downs. You just kind of do it so you can get your waves like that. And reassure them that this is just as real of a biologic disorder as myelofibrosis is. You know, it's a biologic imbalance of chemicals in the brain. So it's not something that reflects weakness on anybody, or shouldn't be something that people should be ashamed of or feel like they're not strong enough if they feel that way. This is something that has a biologic basis and happens just like asthma, diabetes, anything else. So if you have diabetes, you wouldn't say, oh, I'm weak if I have to take diabetes medication. So that's, I think, a key thing to remember as well.
So Dr. Couri, do you want to share your experience in terms of, you know, did you find yourself really frightened or, you know, kind of depressed about this? And
Absolutely. You know, there's so many emotions that go into this whole transplant process. And yes, I was scared to death. I mean, I was basically almost paralyzed with fear. But I think that for me, resilience, you know, I think resilience going into the transplant is incredibly important in terms of how we do and how we heal. But faith, if I didn't have my faith, I think that would be a completely different story. And we all deal with a life-threatening situation differently. We're all our own human beings, obviously. But for me, I had to give it to God. Like, I had to rely on my faith to get me through this. Obviously, my transplant team was incredible in terms of their support. The transplant, and then that's not just the transplant physician, it's the entire team, the transplant coordinator, the transplant psychologist, the transplant social worker. And I talked to every single one of them, and they all helped me. And so, and your caregiver, obviously, and caregivers, but no one should feel alone, because the resources available when you're going through a transplant are basically unlimited, and the centers do an amazing job to make sure that they are accessible to you, and both physically and emotionally accessible.
That's fantastic. And Denise and Andrea, did you experience, tell me what your experiences were?
Well, I think, to echo Dr. Couri and Dr. Palmer, going to a transplant center is so important because the resources are there. They've dealt with all this before. The staff is trained. In my case, I had ET for 10 years and myelofibrosis for 10 years. And I'm a very action-oriented person. And as long as there was a clinical trial or something, I was focused on fixing this, even though I knew all the statistics. So I kept myself very positive. And because I pushed, I'm athletic, so when I pushed myself to do things, the hard part for me was when my performance in my life started to decline because I couldn't do what I wanted to do. So I wouldn't say I was ever depressed, but I was certainly worried, if you will. And then after the transplant, when you're in the hospital, you're so taken care of and everyone is accessible. And even the 3 months after, or 2.5 months after. But then when you go home, and it is scary, I was like, really? I have to go home? As much as you want to go home, you're so coddled by the system that is very scary. But once you do get home, the process of rebuilding physically was more difficult for me than anything else, because got into the mindset of, oh my gosh, am I going to be like this forever? And I used to do this and I used to do that, until I realized that what I was then and what I am now is where I am. You can't look back. And then you start to build up and you get your strength back and you get your stamina back. And it all works. But the process between going home and getting yourself to a point where you feel healthy and vibrant again, it's tough, but it's very doable.
And I want to reiterate.
I was going to say, Andrea, what, from your perspective, having been a caregiver, I had many moments of being scared and depressed and worried about my mother in this case. But from your perspective.
Yes, it was when they made the announcement at the clinic. I mean, you very much live in a bubble there in that 30 days and the subsequent days afterward. You are very much cared for. When they made the announcement, when the doctor team and staff came in, you're ready to leave, Andrea had this deer in the headlight look, like, what? And it was a big deal. I mean, I was elated and yet thinking, oh my gosh, my brain just started running. It's like, we got this to do and this to do and this to do. And when we get home, it's going to be different, and it's going to be different. That's the big thing is life. When you return home, you want to go back to the normal things that you did. You want to return to your behaviors. And in the whole process, I chose to stay in the hospital with her during the time. And my goal was I want this to be a routine so that when we get out, this is already taken care of. It's a habit and I can handle the new stuff coming on. So, in this whole process, you learn that you are the coach, you are the cheerleader, you are the guardian, you are the information keeper, you are the medicine administrator. You wear many, many hats. I mean, my favorite phrases, which were not her favorite phrases, this is normal, this is typical, you're progressing as you are. This is going to pass. It's only temporary. It's a little setback. You're going to get better. It's this constant support for her, knowing, and I kept my eye on the long-term goal. And the long-term goal is, we're going to get out of here. We're going to return to normal. And it's a new normal, but it's going to be normal. You're going to go back and you're going to ride. We're going to go back and we're going to walk. You're going to get to visit with the animals again. You're going to get to go out and visit with people. You're going to go to restaurants. You're going to be able to socialize. Just keep your head going in the forward direction to to get there. And that was probably the biggest thing. And yes, definitely take advantage of the resources at the center. We did massage therapy. We did
right.
lots of that afterward.
Cryotherapy.
Physical therapy, rehab. We did it all and still do. And so that's real important. One of the main mantras that the staff at our center said, motion is medicine. And that is so very, very true. As grueling as it was for her and for me and her sister, we got to go walk, Andrea. We got to do this. She's like, I want to go. And it's like, yes, let's do one turn. Let's do one. And then maybe we can do it. Okay, one. So
Okay,
that's
fabulous answers, and input. We have so many questions, which I knew was going to happen. So hang in there, gang. And for our participants, bear with me. I'll try to get to all of these questions. This is a very good question, Dr. Palmer. Will I be able to carry a baby post-transplant if I freeze my eggs? And how soon after transplant could I get pregnant? I can't hear you.
Sorry about that. So that's a great question. I saw that one there and I was really happy to see it, because this is a really important thing that I think sometimes, even as a woman and understanding, the importance of having children, sometimes we forget. So the answer is yes. If you freeze your eggs, and now they have so many great technologies to be able to freeze eggs, even if you don't necessarily have who will be the father yet. If you wanted to freeze eggs, you can freeze embryos. I mean, there's a number of ways to do this. And then fortunately, the key is making sure after the transplant that you have appropriate GYN support or follow-up to make sure that the hormone replacement comes back. Because for younger patients, that hormone replacement is critical. Now, we all get a little anxious if you have a history of something like polycythemia vera that progressed to myelofibrosis, and then we say, oh, we're going to give you estrogen, which we know can can create the risk of clotting. But all that being said, at that point, presumably that mutation is gone and you shouldn't necessarily have that risk. So that's a conversation you still have to have, though. But the short answer is yes. I think with the appropriate management and with a really good fertility doctor, it is possible to carry a child after transplant, have a child after transplant and do okay with it. And I think it's a great thing to bring up to make sure that you do discuss fertility beforehand, especially if that's something that's really important to you. Because there are lots of ways that eggs can be harvested and frozen and taken care of in a way that we can now manage so many different scenarios and potentially offer that option.
And Dr. Couri, having worked in this field for many years, is there anything you could add to that?
I completely agree with Dr. Palmer on what she said. And I agree, just maybe having the importance of having that discussion, again, keeping the doors open to have that discussion with the patient. So that way she doesn't feel like that door has been completely shut. That aspect of her reproductive life has been, completely shut. And so I think it's an exciting time now to where we have the technology to be able to freeze eggs and freeze embryos and to offer that hope to that young transplant patient so that she can bear children someday.
And another question, what are a person's options if they are no longer eligible for a transplant, Dr. Palmer?
Sorry, I keep muting myself because there's so much noise. So there's, for patients who are older and are no longer eligible for transplant, and again, that's somewhat subjective.
They may not be older.
They might not be, I think for somebody who's not eligible for transplant, whether it be due to age or due to other things, first of all, it's important to know that what makes somebody eligible or ineligible will be based on transplant center. If a local transplant center says, no, you're not eligible, there are sometimes it becomes a matter of the risk and absorbing the risk of what will happen. And some larger centers may be willing to take higher degrees of risk than smaller transplant centers will. So if that's something that you truly want, definitely make sure to explore the options that are other different transplant centers out there, because everyone has their own gauge of where the risk should be and the age limits, et cetera. Now, if somebody truly isn't eligible or doesn't want to transplant, sometimes people hear what I have to say and they say, you know what, I'll take my chances. Now is a really great time in myelofibrosis. I mean, we're starting to see treatments that not just control symptoms. Historically, we've always looked at things that control spleen size and control symptoms. Now we're actually seeing treatments that can reduce fibrosis, reduce the amount of scar tissue present in the marrow, and actually reduce the percentage of cells that are involved with mutations. So we are seeing some treatments that are really breathing amazing hope into what we can do. They still are not curative, so I wouldn't say we'll hold off for these treatments and don't do a transplant. But if transplant's not an option, some of these treatments, I mean, it's amazing the different results we're seeing and sort of some of the benefits these drugs can have for people with myeloproliferative neoplasms. So don't lose hope, because there are a lot of options, and most of these are only available by clinical trials. So you need to find a center that would have that clinical trial available for you. But recognize that we are having more and more drugs out there that are really providing a lot of benefit for patients.
Well, to segue from that question to this one, so do physicians exhaust all the medical or medicine that's available, chemotherapy options before transplant? For example, first we're going to try Jakafi, then we're going to try HU or Pegasus. Is that typically what happens, or is it sometimes a person that has not had any medication?
So, again, like the timing for how I look at it is the timing for transplant is based on risk. So sometimes people can have high risk disease and not have any symptoms, in which case Jakafi is not really going to help you anyway. Pegasus is, especially in myelofibrosis, I see as more of an earlier therapeutic option to help potentially change the progression of the disease rather than a salvage option once somebody has not responded to treatment. So when I meet somebody, one of the first parts of that discussion, even if they're really early myelofibrosis, is where will transplant fit into this? What are the different treatment options and how do they fit into this process of transplant? And that's why it's good to make sure that, either you talk to a transplant physician who's very well versed in the treatments for myelofibrosis, or that your transplant physician and your myeloproliferative neoplasm doctor have a very, very good conversation about that, to be able to really give all the different options that are available. But I think the quick answer is absolutely not. There are patients who I will transplant who have not had a drop of therapy because of the risk and because of where they are with their disease.
So Andrea, were you taking other medications? I mean, were you being treated with other medications for your MPN before you transplanted?
Oh, yes. I was treated with drugs for my ET, and it was just a pill. I didn't even know I was sick, really. And then when it went to myelofibrosis, I was in 3 different clinical trials. The third one, and the reason things progressed is my need for transfusions decreased. So from every 3 months, it went to every month, every 3 weeks. And then I finally found one clinical trial that gave me a stay of execution, if you will, or stay of transplant for 6 years. And while my counts weren't great, they were 9 and 8 and 9, I could function. It's when those started to decrease and that I noticed that there really weren't any more options. At that point, 3 years ago for me, I spoke to my physician, I spoke to my MD Anderson hematologist, and Dr. Palmer. I spoke to everybody and anybody that I could ask questions to. And then I had a pulmonary embolism, which was like, oh, okay. Again, you look at all the things, what the pros and the cons. And when I had no other options, that is when I decided time to go for transplant.
And Dr. Couri, were you taking, I can't remember when we spoke over the years, but I think you were taking, what were you on?
Yeah. So I was on hydroxyurea for years for my PV, and then switched to Pegasus. And then when I got diagnosed when it progressed to myelofibrosis, before I found out about the other mutations, I was on Jakafi. So yeah, I was on a hodgepodge of therapies, but they did their job for a number of years until there was really no other viable option that looked, reasonable. So, yeah.
Okay. And so, Dr. Palmer, can you explain the match levels? Like, what is the minimum match acceptable to move forward with the transplant?
So so when we look at typing, it's very confusing. I actually have a really nice slide that I sometimes use, but there's 5 things we look at. So HLA, A, B, C, DR, DQ. So these are the 5 things. And sometimes DQ isn't that important when we look at the 4. And everyone has 2 sets of them. So if we're looking at all 5 of those, this is your 10. If we're looking at, we don't use the DQ, then here, I'm not very good at that. You take out the pinkies, you have 8. And so when we do the 10 out of 10, 9 out of 10, 8 out of 8, 7 out of 8, that is what we're referring to, is this is our starting point. Now, the DQ is kind of interesting because you might have a 9 out of 10, in which case the DQ is a mismatch. And in my mind, that's the same as having a fully matched donor. That would not limit how I would perceive somebody moving forward with transplant. But a 9 out of 10 where maybe DR is your mismatch or A is your mismatch probably does have a somewhat higher risk. So some, that factors into the decision-making process of transplant. Now, haploidentical, sometimes you will have 5 out of 10 match. Now, we are finding that with related donors, so if you have a child, a sister, a parent who's half matched, they can be used as a donor, and we're really seeing actually amazing outcomes that are quite similar, especially in many, we're seeing it, I don't think it's been tested as much in myelofibrosis, but in other disease types, we're seeing outcomes that are pretty much equivalent to using a matched unrelated donor, and even similar to a matched sibling. So we're seeing that we can use this 5 out of 10 or 4 out of 10 or 3 out of 6, depending on how you're looking at it, donor, and still have good outcomes. And it sounds like that's the type donor that Michele had. So these, these are really the donor situations becoming far more optimistic. It used to be like, okay, well, if you don't have your 10 out of 10, then we can't really do a transplant. But now we're finding that we can, almost everyone will have a haploidentical donor. Not, there are people who are adopted who don't have siblings, don't have children, their parents are too old. But most people will have the option of having a transplant.
Okay, and one of the questions is, how is chemotherapy used prior to transplant, and can it cause a secondary cancer?
I'm sorry, what was that question again? I was just looking at a pen. I was just reading the chat thing, and I was trying to figure out how to send something.
What is the risk of chemo pre-transplant causing a secondary cancer?
So it's actually not that bad. I think we've done a lot of data on it. The radiation-based regimens probably have a 3-fold higher risk of developing cancer, and that's for total body irradiation. But recognizing a lot of that data comes from when we used more radiation than we currently do. A lot of myelofibrosis regimens actually don't involve using radiation. Sometimes they do based, if it's a specific regimen that's being used that that uses radiation. Sometimes we like to stick to the known recipe, but I would say it's very uncommon. And only with high doses do we see that increased risk. A lot of times we'll use a small dose of radiation and not really see any increased risk of long-term cancer. The risk of cancer from just a chemotherapy-based regimen is maybe 1.5-fold greater than the general population. So really not a significant increase. So I would definitely, we always, encourage age-appropriate cancer screening, but there's nothing above and beyond that we recommend doing for patients. I think for younger women, we sometimes recommend starting mammograms earlier. But other than that, age-appropriate cancer screening. So I would say that risk is is fairly minimal, especially when you look at the potential benefit of the outcome.
I have several really good questions for all three groups here. And one is, how do I pick the best transplant doctor team? I'm going to have Jeanne go first, and then I'm going to turn to Andrea and Denise and, get their perspectives, and then Dr. Couri. So Dr. Palmer.
So I think that the decision is one that you have to feel comfortable with. A lot of it, there's a lot of wonderful transplant doctors out there. There's a lot of wonderful transplant centers out there. When we look at the outcomes that are posted online and stuff, you have to take that a little bit with a grain of salt, because there's ways that those can be impacted too. You want to know how many transplants they do a year. That's an important question to ask. How many transplants they do for myelofibrosis, because I do think there's certain things you have to take into account with a transplant for myelofibrosis in terms of how excited you get when the blood counts maybe don't go as high, and sort of perceptions, or degree of comfort with some of the things that are different about a myelofibrosis transplant versus a transplant for another disease. But the most important thing is you have to feel comfortable. And sometimes what that means is you get another opinion, 2 or 3 different opinions, just to make sure that you, at the end of the day, you recognize you're taking a risk on by doing a transplant. And you want to make sure that you feel completely 100% ready to move forward with your decision and comfortable with that.
Okay, and so to Dr. Couri, what was the decision? When did you make the decision to choose the team that you chose? I mean, had you met with others?
Yes, so I actually met with 5 different transplant physicians before I decided to go with the one that I chose. And honestly, the decision just felt completely natural. Once I found the transplant physician and the team that felt like the best fit for me, the decision was a no-brainer. It was like, this is it. And I agree with Dr. Palmer in terms of I had done my due diligence. I looked up how many transplants that center had done, how many they had done for myelofibrosis, how many haploid transplants they had done. So doing your homework pays off. But I think, again, I can't reiterate enough how crucial it is to feel comfortable with your team, and don't settle. If you have to be your own advocate, and if the person that you're working with doesn't feel right to you, and if your insurance allows another opinion, you owe it to yourself to go talk to someone else.
And Andrea?
I spoke to 3 different transplant doctors, and one thing I found, I thought it was important to be close to home. It is not. For me, it was not. I had a relationship with MD Anderson that went back 20 years, so I was comfortable with the system there, but still that was not the determining factor in my choice. I looked not only at the doctors and at the facilities, but I looked at the support staff, because while you'll see the doctors maybe once a day, you're going to be with the support staff and the nurses 24 hours a day. And that's, to me, it was very important. Plus, living in Houston, when I live in Dallas, it really did not make a difference at all. You don't want to go out or see people or anything like that. So being away from home is fine. I did, as I say, talk to 3 centers, and one that I just was not comfortable. The other 2 were tough. I had to look at the different, as you all said, the success rates and the number of cases handled, et cetera. But for me, most important thing was familiarity with the center, feeling very comfortable with the doctor and the support staff.
That makes
I don't have to do that. I think it's really, it's the team effort, and that's what's critical.
Right.
Yeah,
So-
Andrea brought up a good point. I mean, I traveled 1,000 miles to have my transplant done, so distance didn't really matter to me either. It was more the degree of comfort I had with the entire team. And Andrea said it so well, because you do see your transplant doc a fraction of the time, and the rest of the time it's the entire support staff, and they are your family for a while.
That's right.
Great
Yeah.
point. That's really good to know, and I'm sure our audience is taking that in. This patient has 1 week, they are 1 week pre-transplant admission and tapering off from Jakafi. The tapering has been very challenging. Is there anything that can be done to reduce the impact of this tapering process?
Well, not really, unfortunately. I think the tapering process, it can be different, and people have, I think, different ways that they do the taper preceding transplant. It's certainly something that's hard to be specific about advice. I mean, sometimes steroids are used to reduce some of those impact, the effects of withdrawal of Jakafi. Sometimes the timing prior to transplant, the duration of the taper can vary. So it's, I think that it's definitely something you want to talk to your doctor about directly, just because they're much more familiar with what their plan is and what what the case is. So about what the different possibilities are to help alleviate some of that, because it can be an extremely uncomfortable process to taper Jakafi.
Can you explain the different types of transplants, Jeanne?
Right. So when we look at the different types of transplants, first of all is sort of the intensity of the chemotherapy we use preceding transplant. So when we look at conditioning regimens, which is a chemotherapy we give prior to transplant, there's one thing it needs to achieve, and that's it needs to suppress your immune system, the recipient's immune system, so this donor cells can come in, set up, and do their thing. So if a person's immune system is intact, it will kick out those cells right away. So you need to have that immune system suppressed. Now, the bare minimum of just having that suppression of the immune system without having any additional chemotherapy is called a non-myeloablative transplant. And what that transplant relies on is not necessarily the chemotherapy beforehand, but it relies on that new immune system keeping your disease away. Then there's a reduced intensity conditioning regimen. Well, actually, let me go next. There's a myeloablative conditioning regimen. And what myeloablative is basically complete wipeout of the marrow. We give you high doses of chemo. The goal is to help control your disease. But these doses of chemotherapy ideally will wipe out your bone marrow and provide very good disease control, as well as suppressing the immune system. Now, that is reserved for younger patients. There's several different types of myeloablative regimens. So depending on the regimen, the age can vary, and depending on the patient, there's a lot of variables that go into deciding that. But that myeloablative regimen basically means if you don't get any more cells, your bone marrow is not going to recover. And then there's kind of the middle one. So I think of it, like the three bears, you have too hot, too cold, and just right for the porridge. The middle one, and not saying that reduced intensity is just right. It's the regimen I usually prefer to use, but there are situations where I'll use myeloablative or non-myeloablative. Reduced intensity is sort of right in the middle. And that is that you do have some chemo to help with the disease control. So you're using, on one hand, the immunosuppression, on the other hand, you're using chemotherapy to help control the disease. But you don't necessarily use the same high doses that would be completely ablative. Now, depending on the regimen, will depend on whether your marrow would recover its own function or not. But it does provide some degree of disease control. And I think it's what a lot of times we use, especially in patients who are a little bit older, because, if I have somebody who's 68, I would not use a myeloablative regimen. Now, at least generally speaking, there's always exceptions. So please don't say, oh my gosh, my doctor's using this regimen, there's something wrong, because again, these are generalizations. But then reduced intensity at least gives me some aspect of killing off disease as well as suppressing the immune system.
And one of the questions earlier was, if a transplant doesn't work, how long after that would you transplant again? And can the person be transplanted again?
So, I think that the short answer is yes, people can be transplanted again. I've done second transplants in many disease types, including myelofibrosis. In terms of how long it will be, there's so many variables of how that looks. And whether someone's a candidate. Because I think the things that I take into account is, number one, how long did somebody stay in remission? Number two, how did their transplant course go? I mean, if somebody got completely weakened and debilitated and had a very complex transplant course, doing a second transplant, especially early on, can be a big challenge. But if they had a breeze of a transplant course and they're 2 years out and all of a sudden they start to relapse, that's a much different scenario where I think the person will have the reserve to be able to withstand a second transplant. And then it depends on donor. So if you have, you know, the donor is probably lowest on that list, because obviously if you had a donor for the first one, you could even potentially use the same donor. I generally tend to switch donors, not that there's anything that tells me I absolutely have to, but it just intuitively seems like a good idea. So I will always try to use a different donor, but that's not 100% necessary. So, but I think the most important things when you think of a second transplant is how long did it work the first time and what condition somebody's in at that time you're considering it.
So the next two questions I'll pose to our transplant people here with us today, and to Denise, who's the caregiver. But what is the quality of life post-transplant? And I'll start with Andrea, because compared to Dr. Couri, it's been a longer period of time for you. How would you say your quality of life is now?
I'd say it's excellent, absolutely excellent. Am I the same person I was 5 years ago? Probably not, but how much did the transplant have to do with it and how much does age have to do with it? It's hard to tell. The transplant did age me a bit, mentally and physically, but if you work toward getting stronger, there's nothing I don't do. There's nothing that transplant has restricted me from. I ride a bike, I walk, I travel when I can. I cook, I eat everything. I really have no complaints. While the transplant process was very difficult, if I had it to do over, I would do it again because it was way worth it for me.
Totally agree. You couldn't have said it any better. It's a process. You have to be patient. Yeah. You have to stick to your outcome that you want. The mindset is very important. Attitude is hugely impactful on it. Not only yourself, but also to your patient. You give to the patient. Those are the things that are going to get you through.
And Dr. Couri, I know it hasn't been that long for you, and I hope you're doing okay, sweetie, because
I'm doing great.
Okay,
I'm doing great.
I wanted to check on you and make sure you were okay.
Thank you. Yeah, no, I'm doing great.
So in your opinion, I know it's only been 4 months, but I know you have a great family. I met your husband, he's a sweetheart, and so your thoughts.
Yeah, like Andrea, I would say that I feel excellent. I do. I mean, no doubt there are some challenges early on. One of the biggest challenges for me is just the frustration of this pandemic. You add a pandemic on top of a transplant, and it just, that kind of makes things a little hairy. But I hike every day if I can. I'm up to, I hiked every day leading up to the transplant to stay in shape, and I'm hiking again. I think your mindset is huge, and I think your attitude, like Denise said, your attitude plays a very important part in your healing. I think positivity is so important. So I try to wake up each day with a positive attitude, no matter how I feel, and I really try to give it my best every day. And I do have great energy levels. I feel good. I mean, there are changes that the transplant has brought about, but they're pretty minimal, I think, at this point, and I hope they stay that way.
Could you share those changes?
Yes. I had the complete myeloablative chemotherapy regimen, and so it hit my gut pretty hard. And so there was a lot of GI symptoms that I had to deal with after my transplant, both in the hospital and then once I was released a month later, I had to adapt to what I could eat. I mean, my diet really did have to change. So I think that we never know how the chemotherapy is going to affect us. And I think that you just have to adapt. You have to just kind of know your body and know and be able to pivot and make changes so that way you can be one step ahead of what what changes did happen. So for me, it was mostly, changes in my GI function.
That's good to know. I know patients, that are contemplating transplant want to know everything they can possibly know beforehand from those who have gone through it. So this is very good information. One question that is to all of you, but I'll start with Denise and Andrea. How many caregivers do you generally recommend for transplant? Possibly a primary and then backup? And I think you two kind of hit on it earlier.
Yeah, I think that's real critical. It depends on, as a primary caregiver, as I said, I chose to stay in the hospital because obviously this was going to be a long-term journey, as well as knowing everything about her health and in advance. So, but if you are limited in your number of caregivers, do resort to your friends that are willing to help, and I would strongly suggest scheduling in folks who are going to maybe have responsibility for doing groceries or bringing meals to you or getting laundry done. You do need the help. You do need to have the assistance, and it's always good to see a fresh face and get a fresh burst of energy. But I don't think that there's any magic number to it. I think the most important part to it is that participate in the journey with your loved one or whoever you're giving the care to. When Andrea had her hair shaved, I had my hair shaved, and so did her sister. So we all, we were just like Michele here, we had no hair, and then we had the caps, and we had the this and the that, and and it was all part of it. You have to find some levity and some laughter in it, some humor. Is it grueling? Yeah, but don't let it rule your life. Don't let it bring you down. I mean, we had eclipse balls. It's like, well, what's an eclipse ball? We get to go home and play basketball. What's up? And so, you just try to make fun out of it and to get through it. And it's really important. So no magic number. I don't know if you have anything else.
Yeah, I think that the level of care depends on where you are in the process. Mm-hmm. So obviously when I was in the hospital, I didn't need any care whatsoever because it was so good. But the 2.5 months that we were in the apartment, I happened to bring my cat. They allowed me to bring the cat in the apartment. I couldn't hardly touch him or do anything. So my sister was a huge help during the day. I mean, she would do the cleaning when I was back and forth to the hospital. She was really helpful to Denise and I. She would cook. She would take care of the cat. But could we have done it without her? Yes, certainly. Denise would have been much more put upon. But having that other person, now when I came home, really it was just Denise and I handling it. And you really can't have too many people in because of the fact of your immune system being so depressed. So you have to be very careful, and you have to make sure that you're okay with not seeing people for quite a while or seeing people at a distance. So your care really decreases as you get better, if you will.
And Michele, you made a very good point. I mean, we all know we're living in a pandemic. And, I mean, for someone going through this during that time, what would you say as far as caregivers go?
Yeah, so again, my transplant was 1,000 miles away. So my husband was my caregiver for the roughly 25 days that I was in the hospital. And then my sister, we have 6 kids. So after I got released from the hospital, my husband had to come home, and then, be with our children because they're still fairly young. And so my sister took over. My two sisters actually came down and were my caregivers. And the reason why I had two is because, again, because of COVID, one was like the runner. So one went to the grocery store, one was out in, the public, while the other one was, quarantined with me because so it just added a whole another level of, of security and that you have to have with this pandemic. But I was blessed to have the help.
I always said, I'm the youngest of 7, and actually so is Kathleen. But if we ever, there was a moment last year, just in the middle of the pandemic, where I had a scare, and the entire family had, okay, here we go. Who's going to be with her this month or this week? And actually, Kathleen just went through this with a brother had a surgery, and her whole family snapped to, and there was somebody with them with him at all times. So yeah, so that's good to know. That's good. It's so important to understand the role of the caregivers in any situation. It is so important. And Dr. Palmer, you must see this, all the time when you're dealing with patients that are going through transplant. And I'm sure you have this discussion with them, where are you going to go when you go home and who's there? And can you speak to that?
Yeah, so I think everyone, has a different plan. So, there's some times where you'll have several different caregivers. So a lot of times patients, if they don't have a spouse or they don't have a significant other or family members who could be their caregiver, it becomes really stressful. So like, who's going to be that person? And, I think there's a couple of things. First of all, you're amazed. It's amazing how many people will help that you don't realize. So don't hesitate to ask people. The worst that can happen is they say no. So the second thing is you don't need to have the same caregiver for the whole time. So I think sometimes scheduling them works great. I think one of the best caregiver setups I saw was a patient that I transplanted a number of years back, and she would have a different friend come down every week, and they would hang out and do stuff, and then the friend would go home and another person would come. And I think her husband came in a few weeks here and there, but they had a store that they ran, a business that they ran. So, he had to be home to run the business. So it worked out really well. And asking somebody to spend a week with you versus to spend 2.5 months with you is a very different request. And also then work with the social worker. The social workers are really key in giving advice on how to do this. How do you approach somebody? I've had patients who are very independent, live by themselves. It's a real challenge to say, oh my gosh, I'm going to have somebody around me 24/7.
Yeah.
And it's very frustrating, and it can be very taxing. I know people have different approaches when they're sick, but the caregiver is key. You cannot have a transplant without a caregiver. Any place will tell you that. We actually here we request a backup caregiver to be set up, because there are times that even if it seems like, oh, this is great, I have this caregiver, something will happen, especially if it's a sibling or if it's a friend. You can have, let's say, even sometimes if it's a partner or a spouse, you can have falling out, unfortunately, because transplant puts a lot of strain on any relationship. So having a backup person is something that we request. Not all centers, I think, are as important, but we've had some bad things happen when we haven't had a good caregiver set up. So I think the take home here is make sure to ask people, and then also try to break it up into small pieces, because then it becomes a lot less daunting for somebody who's being requested to be a caregiver, as well as, saying, oh my God, this is a friend, but having a friend versus having somebody with you 24/7 are very, very different things. So those would be sort of my suggestions.
And I just to go ahead.
Yeah, I have one other thing to add to that is that one of the things that I set up, and I was a primary person, but in case something happened, I set up a notebook so that we had key information in it that was for Andrea. So if there was an emergency, they knew where to go to get the notebook that had the information that they needed, and they knew where to get the medication if it was going to be an extended issue, if we were in the emergency room or whatever. So every person who came in, or as the backup, they knew where to go. They knew what to get in the event of emergency. So I just want to throw that out there. So
Yes, and Denise did a beautiful story for our website, or for our newsletter, and there's a link to her story in the chat, because she actually made this beautiful spreadsheet on how to take, what to ask, where things were. I mean, it was just unbelievably well done and comprehensive. So take a look at that to our audience if whoever is contemplating being the caregiver. But I had to laugh when you said your sister came. So there's 4 boys and 3 girls in my family. And when my daughter was with me, when I was going through my little saga, she said, well, Mom, who do you want to come first if I was going to need chemotherapy? And I said, not this one. I had my favorites, and I said, they can come first, and it was so hilarious. We laughed so hard because how your siblings, and who's going to be high maintenance and who's going to be the one that can cook and can take care of you, or the one that you're going to have to cook for and drag yourself around. But anyway, so that's important too. But I love the idea of allowing people also, because as friends and people on the periphery who really do love you and want to help and don't know how to help, because how so often we'll say, no, that's okay, we can handle this. But to have them do something that, like you mentioned, laundry, that's a wonderful thing, like just come in and do the laundry one day a week, that would be great, or, whatever. But it's so important. It's such an important piece to all of this. Okay, Jeanne, getting back to some medical questions here. What % of PV patients turns into MF or converts to MF? Is it based on the number of years that you have had the disease? We hear that a lot.
Right. So I would say I usually say about 10 to 15% of people with PV will convert to MF. So, it's definitely not everyone. I've had PV patients who say, well, I'll go into MF eventually. And I was like, no, not necessarily. You can have this disease for the rest of your life, just as PV. It doesn't, as much depend on the years you have it. I think there's probably more that we're learning on the biology of the disease that may predict it, but we certainly haven't, unfortunately, come up with, great predictors to say, oh, you have this mutation, you are going to progress to myelofibrosis. It's one of those things where just like the transplant hanging over your head. I think that the transformation does, and that's a hard one when I meet people with PV for the first time, and I try to explain to them all the different aspects of their disease, because that is a risk that's going to unfortunately be there, and it's part of the disease. But certainly not everyone progresses over to MF.
And so, in discussion about the entire transplant team, and we always talk at our events about if you have elective surgery or if you have an emergency surgery, how do you communicate with the physicians that are seeing you, the surgeon, the anesthetist, whoever it is, that you have an MPN. And so we tell people, make sure your, primary care and hematologist and surgeon and everybody has the conversation about what you have and how to treat you. But how do you bring together the entire transplant team for a meeting with the patient that's going to have that? And I'll ask Jeanne first, and then the two of you, the three of you can speak to that.
So I usually there will be a BMT coordinator. There'll be a nurse coordinator who's going to be your point person. They are going to be probably better at sorting through a lot of that than even the physician will, because it's a very important question. Now, one of the things that if you think about all the people who will touch you during, who will be involved in this journey, it's huge. So. But I think that talking to your transplant coordinator ahead of time will be key. The social worker is an incredibly important part of that team, because they can really help navigate a lot of the issues that will pop up during the transplant. And then, unfortunately, there's probably not a good way. When I saw that question being posted, I was like, wow, I wonder how we could do this better, because they do come in, and a lot of times, like, they'll meet their transplant doctor, they'll meet the coordinator, or coordinators are amazing, and really set such a good start to their process. And I mean, I think we have a good process all the way through, but it's a hard thing to say, how are you going to know who all the different doctors are? And that's something that you just have to kind of do your best with, because there will be a lot of people who will touch you on your journey, and not all of them you'll be able to meet ahead of time. So I think the coordinator is a key person, the social worker is a key person, and talk to them, because they may be able to give you a little bit more insight. Sometimes they can show you like the floor that you're going to be on, and you can see some of the nurses up there. You know, but I would, the great thing about working in hematology and transplant is that I feel like the nurses in every institution I've ever been at, the nurses are top notch. I mean, they really are the cream of the crop of the nurses, and, you know, an amazing, amazing group of people. And I really have seen that in almost every place I've ever worked. So also feel reassured that you'll be in good hands.
So Andrea or Denise, would you like to add to that?
Well, I totally agree. We pretty much saw the coordinator first, and we did take a look at the hospital. I do tell every doctor that I see that I've had a transplant, which I probably will do for the rest of my life. Maybe it makes a difference to them, maybe it doesn't, but you know, they need to know, needs to be in my record. But just to echo Dr. Palmer, the nursing staff where I was unparalleled. I mean, and thank you for telling everyone that other places are like that too. That's great. Denise,
Yeah.
did you know?
And the only other thing to add is, and you don't get to necessarily meet the nurses on staff, but I know that at one point during Andrea's journey in the hospital, she had a fever that spiked to close to 100 plus in like an hour. And I'll tell you what, the staff knew exactly what to do. They came in, we're going to do this, we're going to do that. And it was a flurry of activity. And before we knew it, she was out the door to go get this x-ray. And then she was wheeled back in and off to this one to go to get this test. And we had drawn blood from the arm and from the port and from the IV. And, you know, and it's, yeah. And I mean, they are top notch without a doubt. And it's just, you know, you're cared for. They know what's happening. And if they were off 2 days ago, they walk in the door and they know exactly where you are at that moment. So that's, you know, and that's, again, that's part of that habit and routine that you want to know, so that you, again, know what's going to happen later.
Yeah. And Michele, do you have anything to add to that?
I'm just echoing those sentiments exactly, because the nurses and the techs on the transplant floor are unbelievable. They are unparalleled in their compassion and in their expertise and their dedication. They make the experience. I mean, they, like I said, they truly become your family, and they make the experience much more tolerable. Yeah, they're there for you for everything. I mean, they're just incredibly kind.
Yeah.
That is so good to know. And I hope our audience feels the same way. That is really good to know.
Yeah, I mean, I never felt alone. Like, I never felt alone. I never felt, you know, they are there for you, and they walk the journey with you in the hospital. And I mean, it's a good feeling to know that they're there.
So Michele, because you went through this during the pandemic, were they in hazmat suits? I mean, you know, when they came to see you, and they weren't?
No, nope, just a mask. Mm-hmm.
Wow. Okay. Yeah. So how do you determine what your insurance will cover? I'm not sure who can answer this, and maybe all three of you, or you know, that you all have a response to this. Will they cover our and what the copay would be? And is it possible that our insurance would pay for more for a transplant at one particular center versus another? That's a good question.
So I can take a stab at this to begin with. So first of all, make sure you meet with a financial person at the institution, because there are things that they'll be able to have insight onto much better than myself, or even that the social worker sometimes will have an idea. Remember also, most places, I know we do this here, we did it at my previous institution, we'll give you a list of all the potential medications you may be on and what their copays are and what their costs are. You won't always be on all those different medications, and we work really hard to make sure that we can get authorization for medications and try to make the copay as little as possible. And if we're unable to do that, find an alternative. The final thing is that in terms of the center, there are certain, they won't generally grade how much they cover per center, I think. I mean, I'm definitely not an insurance expert and don't pretend to be one, but there are, like, for example, our center is considered a center of excellence. So there's certain times that people have to come here for a transplant versus another center in town because we're a center of excellence and the other center is not. So that is one thing that sometimes, but it's usually an all or nothing. It's not usually a gradation of pay. Like, well, if you go to a center of excellence, we'll pay everything. But if you go to this center, we're only going to pay 50%. And then finally, remember that we can't predict everything. Even the best, most amazing financial person is not going to be able to predict everything. But recognize that on the opposite end, there's a lot of resources out there that can help. So, for example, we have had patients who have had extra co-pays from hospital stays and stuff that have become fairly unwieldy. And I think the key is if that happens, talk to the institution, talk to the financial people, find out what other things are there. Like, there's a charity care process here that even if you have, a spouse who makes a certain amount of money, that charity care will really help cover a lot of it. So don't feel ashamed or feel bad because this is an expensive experience. There's a huge amount of financial toxicity associated with transplant. So make sure to talk to the financial people, talk to the social workers, find out what options are there to help you, find out what type of payment plan you can go on. Because even if everything looks like it's going to be copacetic up front, these bills can come in and just be overwhelming and stressful. And recognize that we will bend over backwards to try to make it work and try to help you. And oftentimes we're able to make a huge dent in that and really provide some assistance. So, I think one of the instincts would be after all that, and it's horrible people have to go through that. They're going through so much stress for all their treatment. And then to get this bill in the mail and it's just like a massive cut down. Make sure to not stick your head in the sand and just go talk to people about it. There's no shame in doing that. And there's a lot of resources that can help.
Yeah. I mean, that's a good point because my God, medical bills can be so daunting and outrageous and scary. And even for small procedures, and you get a bill from another part of the group that you had no idea they were even, participating in your care at that point. So you really have to be astute. And when you're not feeling well and you're going through all of this stuff, you really, it just speaks to that that advocacy issue and having a partner or family or somebody there that is handling this stuff because it's got to be, it's ominous. Yes.
There is one thing, insurance, I was fortunate, my company paid for everything where I was working at the time, but there are a lot of ancillary costs. Because I was in Houston, I had to get an apartment for Denise and everybody for myself. So usually that's not covered. And in my case, the hospital did give me a list of potential places to stay, prices associated. There are free places that you can stay. There are very, very low cost places. And then you can get an apartment that's more expensive. So you have to not only look at the medical costs, but there are other costs associated.
That's absolutely correct. And Michele, any input on this?
Yes, our insurance has a transplant coordinator who was assigned to my case. And so we worked with her leading up to my transplant to make sure that where I chose is in network. And then she also shared that certain insurance companies, mine did, they have a relocation allowance. So there's a certain amount of money that you're entitled to for lodging. And so you can use that. So the key is definitely talk with your insurance companies. Most of the large insurance companies have transplant coordinators and they can help you to know, because they do have money set aside for some of those ancillary costs, like Andrea said, because it is costly. There are lots of costs that you don't even realize that will come your way. And so make sure that you know what's available for you with your insurer.
Such good information, all of you. I am just so grateful to all of you for being here to share this and how wonderful it is to have, someone that's been out several years, someone that just had the transplant, and a physician that works in the space all the time. I mean, it's just been incredible. And these questions are good questions. I mean, we always marvel at the questions we receive from patients. So let me ask Jeanne this. Do success rates vary country by country? And do transplant techniques differ in other countries outside the US?
I don't necessarily think that the transplant outcomes will be impacted by what country somebody lives in. I do think that different centers have different levels of comfort with it. But I will say that the transplant process at each center is going to be a little bit different. So if I look at how some of my colleagues practice at other institutions versus here versus, we all have kind of our special sauce, our special recipe that we use that we feel comfortable with. And truly, that's what you want your doctor to use. I mean, you don't want to go, stick with what you know. If something's working for you, do that. Because there's a lot of different ways that you could transplant somebody, a lot of different approaches you can take, and there's definitely not one that's right or wrong. So I think when you're looking at different centers, and especially if you get several different opinions, recognize that some places are going to approach it somewhat differently than other places will. And that's why with that question about the Jakafi taper, I mean, there's going to be differences in Jakafi taper. There's going to be differences in the conditioning regimen, the different graft versus host disease prophylaxis, et cetera. So there's going to be a lot of variability. And, the key is feeling confident in your transplant team, your transplant physician, but recognizing that if you go and talk to somebody else, they may give you a slightly different approach they're going to take. And that doesn't mean that what your doctor's doing is right or wrong, or what the other doctor, who we all have slightly different ways that we approach it. And I think it can be very daunting and scary and look like, well, you don't know what you're doing because this person said to do this and this person said to do that. There's a lot of different ways that this can be done very successfully.
So the next two questions, before I go into these next two questions, I will ask these, and then I'll have Dr. Palmer kind of give us a summary of where she thinks transplants are going and some information for our MPN community. And then I'd like to get a little more specific before we end at 1 o'clock from Dr. Couri and from Denise and Andrea, just a little more specifics about, the process that you went through and any information you would like to share with our participants. And this is recorded, so it will go to other folks, that weren't able to be on this webinar. And so first, let me ask these questions, and then we'll go to Dr. Palmer for that. But can you describe the donor process? So what does the donor have to do? Jeanne, do you want to start? And then
Yeah.
I find out from Michele and from.
Yep. So the donor, there's a couple ways that the donor may be treated. The first one is to do a bone marrow harvest. This is not as commonly used, especially for myelofibrosis. We usually like to use peripheral blood stem cells, but the bone marrow product is also good. What a bone marrow harvest is when somebody gets a bone marrow biopsy, which most patients have had. Basically, what we do is we go that same area, but somebody's under general anesthesia. They're in an operating room, and we basically, that liquid part of the marrow that's aspirated out, we go in there and pull out the liquid part of the marrow from somebody, and from there we get the stem cells. I guess just to back up, the stem cells that we use are in the marrow. They live in the marrow. We have to get them out of the marrow one way or another. And so the first way, as I said, is the bone marrow harvest, which again, somebody is completely out for, sedated, intubated. They will not remember the harvest itself, although it can be uncomfortable for a week or so afterwards, if not a little longer. The other way of collecting it, the more common way, is that we give a medicine that makes the stem cells from the bone marrow go out into the peripheral blood, and from there we can actually collect them. from the peripheral blood. And what that involves is giving the donor a shot of something called filgrastim or Neupogen. There's lots of different names for it and variations, but what it is it's a growth factor that is often used to make people's neutrophils, which is one of the types of white blood cells, go up after getting treated for chemo. But in this setting, in a healthy person, what you're doing is you're driving the bone marrow to produce lots of extra white blood cells. What also happens is that helps the stem cells that are in the marrow come out into the peripheral blood. From there, they do a process called pheresis, which is where ideally there's an IV stuck in each arm. Sometimes we have to put a line in the neck, but more commonly we try to use the arms. The blood comes out one side, we spin it around, the stem cells get saved over, and the rest of the blood goes back into the person who's donating. And that process it's about 4 days of injection. So you come in the morning, you get an injection, you go home. And then on the 5th day, you get an injection and they do that procedure, which can take, anywhere from 4 even up to 6 hours. And that's how and the procedure itself is, you're sitting there in a room and it's kind of boring. And sometimes the calcium, your calcium will go down, which makes you feel kind of funny around your mouth and stuff, but there's ways that we can deal with that. Now that process can be very uncomfortable for the donor in that they can get bone pain. We're making the marrow go into overdrive, so it's starting to grow and grow and grow and grow. So there can be bone pain, flu-like symptoms, stuff like that. Sometimes people even require narcotic therapy to help with some of that bone pain. But then once the shots stop, the pain generally tends to go away. And for both types of bone marrow donation, there's been a lot of study done because people do it for total strangers. There's people who volunteer to do it. So it is very safe. And at this point, we've not found any negative long-term implications of being a bone marrow donor. And we have, probably 40 years of experience and 50 years of experience in doing marrow harvests. And now probably about 25 of pretty consistently doing peripheral blood stem cell harvest. So we have a lot of experience to draw upon that shows that it's very safe.
Someone just sent a message that said, how do you coordinate this if it's coming from another country?
So that's actually really a miracle that we do it, but and it's changed a little bit with the pandemic. So with the pandemic, we freeze a lot. So you can actually freeze stem cells down. You have to freeze them in a special compound to make sure that they don't burst. But you can freeze stem cells, and once the stem cell product is frozen, it can last for a decade. It can last for a very long time. It's almost like suspended. And so we often will freeze products. Now, before the pandemic, what we would do is we would have everything timed appropriately. So like the person gets their chemo, the donor, wherever they are, is getting their injections. These stem cells are good for 72 hours. So if they get collected in Germany, you can take a bag of fresh stem cells, give them to a courier. They're usually delivered by courier. The courier gets on a plane, flies them over, and physically brings them to the transplant center or wherever the stem cells are processed. And so that's how we historically would do it. And, you'll say, well, what about weather? Or what? I remember Iceland had volcanoes, like huge volcanoes, and nobody could fly from Europe because of the smoke. Even with that, we didn't really have delays because worst case scenario, let's say that something happens and there's a massive blizzard wherever your stem cell donor is, and they're getting collected. You can always freeze those cells, and even if the infusion gets delayed by a week, I even had a situation where I had a patient completely conditioned, and the donor backed out last minute, and we just infused the stem cells. I think it was 10 days later, and we still had a very good outcome. So all of those things that you say, oh my God, this could happen, and this will be terrible if it happens, we usually can work with. I've seen a lot now at this point where, donors back out, donors get sick. And usually your center, like we always have a backup donor. So I always have my plan B or plan C, even if it's a related donor and I'm not at all worried that they're going to bail. We always have different options available. And if you get chemotherapy and don't get your stem cells right away, it's not the end of the world. I've definitely seen a lot of successful transplants where we've scrambled at the last minute and the stem cells have gone in 2 weeks late.
So before I speak to the others on this subject, I know you have to go see a patient. Could you just give us a summary of, what's happening there and what you see in the future for MPN patients, and in this case, myelofibrosis patients, And do you ever think that MPN patients with, let's say, PV may be able to be transplanted at some point? Because we do have a lot of patients that will call us or email me and say, or at our events say, I am miserable. I would love to have a transplant. Please tell me I can do this. And so would you just share some of that with us before you have to go?
Absolutely, absolutely. And I might be able to hang on a little bit longer, but I think it's good to summarize, just in case I do have to step away and sign out. So I think the most important thing that I want people to remember from this is there is hope. We're getting much better at this process. I think transplant is an amazing curative treatment for this. It definitely takes a huge hit out of your life. I mean, it takes a year or two where you may not be, you won't be feeling the way you want to. You won't be able to do the things you want to do. But on the other end of it, there can be a very rich and rewarding life and good survival time. So remember, there is a lot of hope to this. There's a lot of people who are survivors and have very, get back to extremely active lives after their transplant. I think that the good news is our therapeutic options are getting better. I think that one of the things I'm really looking forward to seeing is how we can utilize some of these newer therapies that have more benefit on the disease modification as either before transplant or after transplant to help prevent relapse. So I think there's a lot of options and a lot of ways that we can even get better at what we're doing for outcomes. And then, let's see. Again, remember, feel comfortable with who you're talking to. Talk to a transplanter early, even if it's too early for a transplant. Talk to somebody, because you can really kind of get your head wrapped around it. You can get your life in order, what needs to happen to get that set up. Because it is good to have that time to process it. The way I tell people is, I'm going to give you a lot of information. It's really going to be scary. But what I want you to do, since we don't have to rush into a transplant, is put it in a box in your head, pull it out, go through some of it. Once it gets overwhelming, close that box up, put it back in the closet, and process through it that way. And the more time you have to do that, sometimes the better it is and the more you can process it. Because it is an overwhelming experience. It takes a lot of resources about time, patience, resilience. But again, I've seen so many people go through this process who thought they wouldn't be able to, but go through it and come out very successfully on the other end. So there's a lot of hope. There's a lot of excitement in the field. I think in general with myelofibrosis, we're making so many amazing leaps and bounds in the treatments that we can offer. And I really look forward to seeing how we can weave together everything that we have to offer in terms of treatment options, transplant options, and really create the most successful outcomes possible for patients.
I agree wholeheartedly, and thank you for that. And so, Dr. Couri, what would you, impart, like in terms of your story, chronologically, kind of when you were diagnosed, when you change, when things started to change to this transplant that you just so recently had, and then what wisdom you would like to impart that you haven't yet to this audience.
Yeah, I would say a couple of things come to my mind. One is, don't let fear keep you from having a transplant. If your physician feels that you're a good candidate and you feel comfortable moving forward, I think the fear component is so harmful, and it holds a lot of people back from what could be a healthy, beautiful, long life ahead of them. And so I think have confidence in who's taking care of you, and know all of your options. But if I talked to several people who had a transplant before I had mine, as I was preparing for this process, and they all seemed to be doing well. And yes, they all had some ups and downs, and nothing was, perfect by any means, but they all were happy and they were all thriving. And I think the more we can get that message out that transplants have evolved and they are evolving, I think less people will be blinded by the fear when they hear that word. and they can digest that information a little bit better.
And Andrea?
I think I totally agree with the fear factor issue. It is a scary process. You just can't let fear overtake you. Speaking to people, I am available if anyone has any questions. Anne can give my contact information. Happy to impart any knowledge. I spoke to transplant recipients. I spoke to doctors. I went online, and let me just caution online. There are a lot of things that are incorrect. Go to the right sources, like Anne's organization. There are several different MPN communities out there. There are support groups. I used to lead a support group in the Dallas-Fort Worth area. There's probably one near you where you can talk to people. And I think the most important thing is don't wait too long. It sounds strange, but go when you're feeling good or when you're healthy, because your chances of recovery completely and quicker are much higher. Denise?
Yeah, again, just echoing what everybody else has said here, educate yourself about, as a caregiver, educate yourself about the process, know what's going to happen, what's the first step, what's the next step. I mean, I looked at it in phases so I could break it down and understand what I needed to do to be prepared, when I needed to go into action, what I was responsible for. And I think one of the big things that I was responsible for, obviously, aside from her care, is not to minimize that, but you also have the medication, and not everybody's different. But I know at one point, I think Andrea was on 17 different medications, not including her normal, if it was high blood pressure or cholesterol or anything like that. So you need to know that, number one, that medication is going to change, and it could change from a day-to-day basis. It could stay the same. You need to know when it's given, how frequent, with what, be organized about it. And if you're going to have several people come in and take care of you, that becomes a very important piece to the next person who's responsible for the patient during the transplant process. So medication is important. It's typically what you find out in the process. It's normal. We've seen this happen. We'll take care of it. That's what your center is about. They know the ins and outs. They've seen it all, and they can handle it. Be patient. When you,
it's hard.
and I'm gonna tell the caregivers, you will be responsible. At least I was responsible for cleaning her port, and so you have things that you have to do on a regular basis. As the patient, I would wear a button-down shirt so that they can get to the port easily and get it cleaned. And that's just a daily little tip. They'll tell you all this stuff as you go through it, but as you prepare, button-down shirts are great. Make them comfortable. Slip-on slippers and shoes, easy. Make it easy. Make it happen. Klingon wrap, like Saran wrap, is your new friend. As you put that on your port when you go in to shower, you need to keep it dry. So, and they'll go through all this kind of stuff, but just some tips, thermometers, all that kind of stuff. So,
I mean, your information is so outstanding from, and we do have that on our website in our resources, and we will get it back out there. I think it's in the chat right now, but all right. So these are medical questions, but also for all of you. Dr. Palmer, does having a smaller spleen seem to create better results from a transplant?
So that's a very good question, and I think one that we continue to learn more about. Since we have medications that really can help shrink the spleen, we've been using those medications, and such as ruxolitinib or Jakafi prior to transplant, and I think that we've seen some very good outcomes in doing that. Just recently, there was a couple of publications looking at splenectomy again, which was something that we really have not done as much of in the presence of having these great medicines to shrink spleen. And I think in the right person, and again, this is a very nuanced thing, splenectomy may be something that could help prior to transplant. Again, it's a very, very specific decision-making process to go through to do that, because a procedure, especially if the spleen is very enlarged, can be tough. Now, all that being said, I think the spleen is one of a number of different factors that contribute to how the transplant will go and what the outcome will be. So I think that, again, the nuances of it are definitely a discussion to have with your doctor, because it certainly goes beyond the scope of what I could say in a little catchphrase. But I will say that, you know, I've done successful transplants in people with big spleens, with small spleens. So it is something that is a variable, but not the main one.
And so to the patients here, was your spleen size a factor in deciding, you know, was that one of the issues that you were having, like an enlarged spleen? You know, I didn't, yeah, Andrea, I mean, Denise.
Yeah, no,
No.
she didn't.
Right.
I had a big spleen at one point. It reduced, but that wasn't.
That wasn't an issue. And Michele, no?
No.
Okay. So in wrapping this up, and Dr. Palmer, again, thank you for staying on so long, because she found out this morning that she had a patient that she had to see very soon. And so first of all, I cannot thank all of you enough. I mean, just a brilliant conversation. I love the fact that we've been able to do this and get this out to as many people as possible in our community. The information is so important and so valuable. So in closing, we have a few more minutes here. Let me start with Michele. You know, anything else that you can think of that, you know, from start to finish? I think you said 20 years of polycythemia vera. Was that correct? I may be
10.
10, I'm sorry.
Yeah, that's okay. Yeah. So my one piece of advice is, and a fellow transplant patient told me this. She said, every day that you're in the hospital for your transplant, walk every day in the hospital, no matter how bad you feel, and make yourself get up and take a shower every day. And I know this seems trivial, but honest to goodness, there were days that I'd walk 3 miles in the transplant unit a day in the hospital. And it then just progressed how quickly I was able to get stronger and was able to get out of the hospital. And then it just kind of trickled over into me being able to walk as soon as I got home and got to the apartment, and have a caregiver that's a motivator, because that's huge for your recovery. If you have a caregiver that will push you and you know, stay on you to do better and better each day, and always stay active, because it's really so important for your mental health in addition to your physical health.
And Andrea?
I think one has to always keep in mind that everyone is different. So while you hear a lot of stories or you read a lot of things, you're a unique individual and your transplant is your own. Also, I think preconditioning is very important. If before your transplant, if you could do band exercises or walking or whatever you can do to get physically stronger, as little as that could be, is important, because you lose a lot of weight, and a lot of that weight is muscle mass. So it makes it very difficult to sort of start up again. I was different than Michele, because it was really hard for me, as athletic and active as I was before. I started with maybe 3 steps down the hall, and it was just difficult, but it got stronger. So keep a good attitude.
Yeah, keep a good attitude. And move. There's nothing else that, you know, you can't top it. It's in your very worst day. If you have to crawl down the floor, which they won't let you crawl down the floor, get out and make it happen. Yeah, and don't forget, your phone is your new best friend, because you can set alarms for when meds are due. Yeah. That's a tool.
Right.
Sharing bridge. Communicate to your family, your friends that way. Andrea had a very large group of friends that we needed to keep up with. So the daily posts were very, very helpful.
Yeah. Well, again, I don't know how much I can say this, you know, it's just never enough, but thank you all so very, 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 very much. And please take care of yourselves, continue to take care of yourselves. And, you know, if you need us for anything, I know you have families and friends and, you know, but no matter what it is, if you think that we can help in any way, always call. I'm here. I mean, I might have to call you back, but I'm here. And God love you, Michele. I mean, you just, I didn't even know she had actually gone through the transplant process. And we have, you know, we communicate, not regularly, but often. And I was just so shocked and just so grateful to you for being here today. And
Of
get some
course.
rest and take care of yourself. And Denise and Andrea, it's so good to see both of you. Yay, you know, I'm just so happy. And hopefully, you know, if we can ever get herd immunity in this country and you know, get back to something that seems normal, I do hope I get to see you in person, you know, in the near future. And lots of love to all of you.
And thanks for putting
Thank
this
you.
together. I think it's very important.
Yes.
Yes. Thank
But
you,
it-
Anne.
Thank you.
This was great.
Happy Easter if you celebrate, or Passover.
Yes.
Absolutely.
Okay, take care, all of you, and thanks again.
Thank you. Bye, Andrea and Denise.
Bye-bye.
Bye-bye.
Bye, Michele. Nice to meet you.
Nice to meet you
Best of
too.
luck.
Thanks for all your great advice.
And please, I'm available.
Yeah.
Okay.
And me too. If anybody needs anything.
Okay, thank you.
Bye.
Bye-bye.